Sorry for being redundant because I've briefed this before, but make sure you understand this is a single seizure lasting 5 minutes or more, or 2 seizures or more where they never return to baseline. No recovery of consciousness. So this can happen to somebody that has seizures. This can happen in their very first event. So no gauge on that. What I want you to pay attention to here, obviously what's highlighted, usually subtherapeutic and anti-epileptic levels. What that means is that majority of these people are actually going to be people that already suffer from epilepsy, and then they have this breakthrough that happens and they can't get it under control. Keep in mind there's a whole bunch of other different things. I want to warn you that we get concerned about infections, especially people that are immunocompromised, and then we worry about metabolic abnormalities, and then also any type of alcohol or drug intoxication or withdrawal can also result in this. I say this is a scary thing because these are less likely to terminate, less likely to be controlled with medications, and likely to cause some pretty significant sequelae, meaning that they're going to have some long-standing issues after this. Not just necessarily mortality, but definitely morbidity. So it's going to leave them with something that's going to be lasting for the rest of their lives, some type of deficit after that. So we talked about this several times, just to make sure you're very clear that non-convulsive status epilepticus, the patient continues to be comatose, they're not actually seizing anymore. We need to make sure that we get that with an EEG. So prolonged post-ictal period, subtle motor signs, just a little bit of twitching, eye blinking, eye deviation. They're going to fluctuate pretty good, and then it's just unexplained stupor, confusion. In older folks, hopefully you have somebody who's a good historian or bystander that can fill this information for you, because obviously the patient is not going to be in a state that they can explain that stuff. So for your visual folks, this is a great slide. I would definitely know this slide for sure. And I'll break it down after this rather than trying to walk the dog on this. But just pay attention that the first thing that we reach for is going to be a phenytoin. The next thing we're going to reach for is either phosphenytoin, or in some cases levetiracetam, also known as Keppra. If we reach both of those, meaning 2 drugs, and by the way, it can be multiple doses of benzos, but if we've used 2 different medications, now we're in refractory land, and then we have to bump down to the next level. That's just a big picture here, but I'm going to walk the dog on this for you in steps. So obviously step 1, we're going to stop that seizure. It's going to be difficult, particularly if that person continues to seize, but trying to get IV access. Make sure that we get a bedside glucose and then get your safety net in place. Very important. Because why I said that people go apneic, so it's very important if they're in the emergency department that you reach for O2 and at least strap that onto them while they're convulsing. Again, we're going to be putting some type of pads on the side of the gurney so they're not banging their body against that and hurting themselves. Potential, once we've gotten to status, that we need to secure the airway. We need to secure the airway. So sooner than later, because they go apneic, and if they're seizing for more than 5 minutes, that's not a long time that we want to let that person be hypoxic. So what do we reach for if we need to intubate them? We are going with succinylcholine. And why not rock? Long acting, right? Long acting. We need to, you're going to want short acting, and nothing's going to upset your neurology folks if they're coming down and seeing this person seizing and you paralyze them for a long enough time, because they're going to want to do some more studies. They're going to want to do some more physical exam and evaluate your patient. They can't do that if you put them on a long acting paralytic. So obviously sedative before and then paralytic. But succinylcholine. What do we got to be careful of with succinylcholine? What types of things? Contraindications. Burns, crush injuries, anything that would cause hyperkalemia. So just be careful with that. So we need to arrange for EEG monitoring there and come down and see exactly how bad is this. But again, highlighted there, glucose, we've talked about these things, but this is status epilepticus. Make sure, just so you know, BMP, it's most of your electrolytes minus your calcium and magnesium. You need to order those separate, and then a lactate. how bad, how long this has been going on. It's going to give you an indication of that. What is the lactate good for? So we'll get more into sepsis. Gives you an idea of how bad is the sepsis. Lactate's really good for somebody, for an alcoholic that's been on a bender. I've seen lactates like 15. Like that person can drink for days. So you've got that much alcohol in your blood system. Yeah, you're not perfusing enough oxygen and take it over. So, and then appropriate HCG, tox screen, and anticonvulsant. So give them glucose because they're probably burning through that glucose storage. Again, hyperthermia, make sure we're monitoring all these things. When we do eyes, nose, so they're going to get a urinary catheter, so we need to see how much is coming out, and then potentially an NG tube. Please take your opportunity in the emergency department to place an NG tube. If you put the order in, ask the nurse, hey, can I do one of these? It's an experience that just very, very interesting. Patients don't like it, but anybody here had an NG tube before? Very exciting, isn't it? No, it's not. Not at all. But if they're seizing, probably not going to get it. Anyway, so toxic ingestion, perceived GI decontamination. Yeah, there's a couple different things. I recommend if you are concerned about an overdose, the first person that you're going to call is poison control. They're going to advise you on everything. So that particular person here in San Antonio, every time that I've called, I've gotten Dr. Sean Barney. He's over at UTL Science Center. Awesome dude. He gets on the phone with me and walks me through things. Not just because they're going to advise you, but they also need that data to figure out, oh, what are the kids doing nowadays? Or adults, whatever. Gives them good demographic information. So clearly, if you are worried about meningitis and encephalitis, yeah, you're not getting an LP on a seizing person. Good luck with that. I don't care how good you are. I don't know how many people it would take to hold that person down so you could do it, but don't mess with that. If you're worried about encephalitis, meningitis, just go ahead and give me antibiotics. Let's get it going. So keep in mind that it can have a little bit of stress-induced peripheral leukocytosis. Don't be worried about that. And of course, they are not going to be getting an X-ray, CT scan, or any of that stuff while they are in the status. So drugs to reach for, benzos. Benzos is number one. If that person was in an EMS rig, chances are they probably got some before. So, and you can switch back and forth between lorazepam, diazepam. I'm going to tell you that the book answer from Kitnally, lorazepam is going to be your go-to. I'll talk about that a little bit more. Based upon your medical treatment facility, a lot of those places have a status epilepticus card. They will hand that to you when you get to the ED and work. It's just behind your badge, and you can just work that guy out and be like, oh, okay, here's what we're doing, here's how we're going to treat that. So some places do prefer diazepam. Not my cup of tea. Why? Lorazepam, slightly slower onset, but longer duration. Right there on the slide, longer duration. So reach for lorazepam first. You can give that IM, IV, IO. However, just realize you get 3 minutes versus 2 minutes, but you're looking 12 to 24 hours versus your 15 to 60 minutes. So obviously, in my opinion, that's the easier choice. Make sense? Lorazepam, right there. Initial choice. More effective than phenytoin, phenobarbital is the initial drug. After a few doses, so you can probably try a couple doses, see if we can get them under control based on what the inciting event was. But then we can reach for phosphenytoin, levetiracetam, valproate. Again, I'm not going to get in big on the doses of that, but here's the next one's breakdown. So 20 makes it a little bit easier. 20 for each of those. So can be given IM. That's the advantage of phosphenytoin over phenytoin, because phenytoin has to be given IV. If you're getting to a point you just not establish IV access, phosphenytoin is going to be your go-to. Once we've given that and it does not resolve it, we are in refractory land. Okay? 2 different medications, not 2 doses. Most of these people, I'd say, if EMS gave 2 milligrams of lorazepam in the rig and they're still seizing, they come in, they're still seizing, I'm going to give them another 2, maybe another 4. Probably going to try at least 3 times before I reach for number 2. So levetiracetam is getting much more in tune. So just know that this, I'm not going to get in the weeds. Again, you should have a protocol in your emergency department in phase 2 that will say, here's we've done our studies and here's what we're going to recommend. Guess what your hospital is also going to recommend? Here's your second medication if we're going to treat UTI, because they've done the biograms for your area of the United States. And they say, nope, we're not going to go with this. We're not going to go with nitroglycerin for UTI. We're going to go straight to this medication, this antibiotic. So just be aware of that. There's standards of care within your own MTF that you need to be aware of. So again, this has not been FDA approved, but it's gaining a lot of traction as a medication to go for. So if I would say, I tried phosphatidylcholine, it's not working, not doing anything, if we're not getting results, we need to do something different. Let's go for capper number 3 before we jump down into the refractory land. So again, refractory right here, despite 2 different anti-epileptics, usually we're getting past 60 minutes. If you think somebody seizing for 60 minutes is a good thing, it's not at all. That lactate's going to be through the roof. By the way, during that entire time, there's a shallow breathing or damn near apneic. Damn near apneic. So then we reach for other medications. There's the other medications you look at: propofol, midazolam, barbiturates, such as phenobarbital, pentobarbital. Those have kind of come out of favor a little bit, but just be aware. Anytime we're giving these other medications, we've got to be very cautious with these patients because they can get hypotense. They're going to get more altered. You're treating them, they're already altered a little bit, now you're going to give them benzos and other medications, now they're going to get worse. So you need to make sure we're probably giving them IV infusion to combat that hypotension. And then at that point, you should have, if you're getting in refractory land, that patient should be intubated immediately. Intubated immediately. So propofol, pretty amazing medication. So very quick on, also very quick off. What do you got to be careful with propofol with? So egg allergies. But great medication, very fast on, fast off. This is probably see a lot of this if you do your surgery rotation and you get to see people getting scoped. So EGDs or colonoscopies, propofol is a great medication. Great medication. Higher doses, just be careful. Anytime you're giving somebody anesthetic, you're giving somebody sedative medication, you want to make sure you're monitoring their vitals. Be very careful giving morphine to somebody who's hypotense, unless you want to do compressions. If not, be very careful with that. So hypotension, propofol infusion syndrome. So people can have emergent reactions to ketamine as well, so be careful with that. Midazolam, that is a juiced up benzo. That's way stronger than diazepam or lorazepam. So titrate that up. Just be careful, that can cause some renal insufficiency if you go too quickly. So let me break all this stuff down for you right here. So barbiturates are your third line. So here's your current recommendations. Again, barbiturates, very concerning for depression, respiratory depression, hypotension. So at that point, they're refractory. You should have a tube, so you should be able to bag them through that. Or put them on a vent. But propofol being your first, midazolam, and then barbiturates. In that order is what I recommend. So it's recommended by technology. So ketamine, also a third line. Just you'd have things in your repertoire if you're hitting a point where, like, what do I do next? Don't be super concerned about this stuff in phase 2. You're going to have an attending with you. You should be not on your own. When you take your pants, you are going to be on your own. So you need to know what to do in these types of instances. So again, this is more recommended, pretty much study driven. You're going to have to get into evidence-based medicine. That's part of why you are doing your master's seminar stuff, so you can look at research and decide that's garbage, that's good, that's clinically significant. I'm going to use that in my clinical practice. There are times you'll get savvy enough that you feel comfortable with trying some things out. This would be like, I've tried everything. I've given a barbiturates. I've tried propofol. I've tried midazolam. I've tried the barbiturates. Now I'm going to try some ketamine and see. So at this point, 60 minutes later, like, this is kind of last-ditch effort. Okay, ship's going down. So succinylcholine, we have to intubate. Talked about that. Beware of rhabdo, hyperkalemia. So that can be more dangerous. There's potential that you do need to think about rocuronium, but just be careful about that. You don't have to worry about hyperkalemia, but that paralysis is much longer, which makes it very difficult. There is a reversal agent, so if you have to and you're really worried about crush injury, rhabdo, you can go with this. There is your reversal agent, Sugammadex. So keep in mind that's probably not going to be readily available right next to the bed with this patient. So think about that before if you're going to go down rocuronium. And of course, that person's not going home, right? Clear on that. Uncontrolled seizure needs to come in, should be intubated, should have RT. If you're going to intubate, have RT at the bedside. Why? Because RT sees every intubation. They're going to help you out. They're going to hand you the tube. They're going to get the ventilator right there. Everything's set up. So call RT, have them down there early. If you have any questions on that, Anthony Rakowski, who was one of the new instructors in the junior class, was a respiratory therapist. Wanted to talk to a TA that was doing that about anything like that. He's your guy. When he turns your way, let me know. I'll step him up. Questions on status. We've got some nice slides there to refer to. I'm not going to get super in the weeds, which is why we're going to talk about check on learning. And then we'll do that here. Come on. Questions? Questions? Bam. So for whatever reason, I'm going to tell you right now, so obviously B, C, D, not going to work. A, for whatever reason, the hospitals prefer diazepam to treat alcohol withdrawal seizures. But it is a benzo, so lorazepam, diazepam. Some places prefer lorazepam. I'm just giving you an idea that in downtown Harborview, they wanted diazepam all the time. It's just their protocol. Just be aware. The point is benzo. Benzo first line. Known seizure disorder. Turns to baseline, so we don't need to get fired up, right? Everybody agrees that B is the answer, right? We're going to send this patient home. We're going to get their glucose to make sure we don't need to treat that hypoglycemia. Maybe they seized and burned it up. We're going to call their glucose storage, treat that. We get their lamotrigine level for their neurologist. Maybe if you want to be a nice guy, just call the neurologist part. Hey, so-and-so came in, glucose is fine. Just maybe give them a call in a couple days. Or hey, call your neurologist tomorrow and let them know you had a seizure. But everything came out fine and follow up on your lamotrigine. So any number of things, we talk about that. Most of the time it's because they missed the dose, but sleep deprivation, a number of those things. Should be an easy one. If there's a change in the seizure pattern, we need to treat it like it's a first time seizure. Okay, easy workup. So A is your answer. Well, I didn't ever lecture you on C, D, and E, so please don't consider this I don't lecture on. Some people do. It's happened before. You guys are a smarter class, okay? So obviously you're down to A, D, right? But I told you which one is the wonky one that people get confused as it's more of a psych issue. And that's going to be A, your complex partial seizure. Okay? Lip smacking, unbuttoning, buttoning, zipping, any type of hallucinations are probably going to be there as well. Clear on that? What's interesting about this, I don't think I had a single question on static epilepticus on my handwriting. That being said, you will have a test of questions on this.
To a degree. An extra 1,400 hours isn't just time regained. It's the chance to earn a degree that can shift your future for depth.
That is your opening for syncope. So syncope, passing out, near syncope, reference, serial, objectives. So what I want you to pay attention to is syncope, near syncope. Should that be any different? Did you treat that any different? No. No. I work up syncope and near syncope the same exact way. Because it just means the person would get to a point that they completely passed out, but they felt like they were, which means that there's some mechanism that caused that. Majority of the time, not to be concerning. We'll see. There might be a couple of you when we do IV lab. We'll find out. I've seen students turn like the shade of the Hulk, get all vasovagal and sweaty on me, and like, gotta sit down. Don't do it in the goat lab. You're standing up, you'll fall down and hit your head. You don't want to have to send you to the ER and get a CT scan. It's no fun. Anyway, there's your lecture. I just want you to be clear. Syncope, near syncope, don't treat them any different. Don't treat them any different. Now, there's more syncopes that are more concerning. We'll talk about that in lecture. So, majority of patients have no issues. Benign cause, vasovagal, orthostatic hypotension. My son decided he didn't want to eat any of the camp meals when we were hiking in the Olympic National Forest. On the last day, he vagaled, and I had to pretty much carry him out of the canyon. He was just adamant. He said, "Dad, why did I bagel?" I was like, "You didn't bagel, son, you bageled." But fair enough. Hasn't happened since. Anyway, so history, physical examination, EKG. If somebody comes to you and says, "What is the most important thing that you're going to order and work up on a patient?" That's an EKG. And we'll talk about the things that we're about. We're about WPW, we're about long QT syndrome, we're about HOCM, Brugada syndrome, those types of things, EKG. There's a couple other wonky stuff that have to do with certain ethnicities. I'm not going to get in the weeds with that, but just understand, everybody that comes in that has a near syncope or syncope is definitely getting an EKG. That should be done by the time they're in the room. As done in triage or right away when they come in the room. You should be able to walk up to the door, EKG is right there, pull it out, look at it. Hopefully, they've had an EKG before, so you can compare the two. At least ask the tech, hey, is it had an EKG before? If they're younger, probably not. Older people, definitely. So you can at least compare them to see if there's any acute changes. So, introduction, brief loss of consciousness, inability to maintain, because that's what the body does. It's like, I gotta reset myself, I can perfuse my brain, my heart, everything as soon as I get laying on the ground. So it's the body's natural reaction, no medical intervention. So we have 1 to 2% ED visits, 6% of hospital admissions, near syncope, same risks. Do not treat them any different. Same thing, same mechanisms that cause that feeling. So just be aware that young and old people can have this. Younger, probably going to be more likely vasovagal. Older, greater morbidity. So do not change your workup. Your pathophys on this. So underlying cause, 6 seconds, complete disruption of flow or reduced cerebral perfusion anywhere from 35% to half percent. So decrease in cardiac output, which is why we should be concerned about syncope. Be concerned that it is a heart issue. The heart is not pumping properly to perfuse the brain, so we need to be concerned about that. We don't get enough O2, we don't get enough glucose, and the substrates don't get to the brain, so the body's going to restore that naturally by getting the supine position. That ensures that we have restoration of that perfusing cardiac rhythm. How's that break down etiology-wise? Right there. Number one, they did this awesome Framingham study, heart study. They basically studied 3 generations of people from 1948, I think, an N of like over 5,000. That's pretty significant. And here's what they found out from that. Majority of that, they don't know why they see device. They don't know why they see device. And then obviously next one is vasovagal. What we're concerned about is that 1 out of 10, that's cardiac cost. Cardiac cost. And we have certain type of tools that we can use. I'll show you those here in a minute. But if it's that cardiac, here's the things to worry about. And that splits between, is it a structural issue or is it a dysrhythmia issue? Are we necessarily going to figure out the structural issues with an EKG? No, that's more designed to handle those dysrhythmias. Whereas a structural, so hopefully you get good enough at your auscultation of the heart that you can hear these different types of things. What's systolic murmurs, diastolic murmurs, what's a click, different types of things like that. But the majority of that is probably going to be figured out later with an echocardiogram. So we're going to do that. Do an ultrasound of that. They can look at those types of things. But we have aortic stenosis there. What's that? That's chest pain, shortness of breath, with a murmur. Just pay attention. One of the weird things on there that I would pay attention to, reason to get a chest x-ray, reason to potentially get a D-dimer, pulmonary embolisms. So we have a clot that is in the lungs, can result in that as well. Then we have our other ones that are concerning vasovagal being at the top there. Being number 2, make sure that you can understand that. Some people can Valsalva, this can happen, they can be pings, it can happen, they can be taking a number 2 and pass out on the toilet with their heads, those types of things. And then you have this weird carotid sinus syndrome, POTS, postural orthostatic tachycardia syndrome. That sounds to me like orthostatic hypotension, but somebody must have got like a good OER block or something. Sorry about subclavian steel. Medications, we always get concerned about, EMEDs, they take too much, older folks can do that. Breath holding in children, I get a lot of questions. My kid doesn't get candy and they hold their breath. They'll breathe eventually. It'll be fine. Don't freak out as a parent. Let them do it. It's fine. Just make sure you spank them when you get home. All right, license diagnosis is important, especially with the cardiac. At 1 in 10, we need to be worried. Double risk of death. And the neurologic increased by 50, unknown cause, that doesn't help me out, increased by 30. I'm glad that Tim Nally told me that doesn't help me out clinically in any way, shape, or form. So, vasovagal, most of those people know that. That can come out of nowhere. So, some people don't want to be in the medical field because anytime they see blood or IVs, they pass out. Again, we'll find out in IV lab. It's okay. You can be completely fine for years and it comes out of nowhere, or it just kind of happens. There's also vasovagal from pain. Anybody seen somebody, they hurt themselves really bad, and they just pass out? My wife does that. If she hits like her knee or something, I just grab her. In 5 minutes, she's going out. At least I know it happens. Because I'm so handsome. Whatever. Cardiac related. This is the most dangerous type. You need to tease this out. And by the way, older folks are not going to be 100% straight with you. They're not going to say, oh, I passed out, they said I tripped on the dog, I did this, or not. They don't want to claim a mechanical fault because they know they're going to have to come to the hospital. Some of them don't mind, but some of them are going to BS with you. You got to make sure, because look at that 6-month mortality rate is greater than 10%. We have structural as well as dysrhythmia, so think about that. With the EKG, should hopefully take care of the dysrhythmia part, but keep in mind that's a snapshot in time. And if they're going in and out of that, so what I click a button on is I say monitor, which puts them on telemetry. Everybody understand telemetry? That person is hooked up, has leads to them so that we can watch that stuff. And if anything arrhythmia comes up, it's going to record it. And I'm going to have them on that the entire time they're in the emergency department. So if they do have an event, and I may admit them and put them on telemetry. See if we can catch that. Yeah, good luck sitting everybody at home with a heart monitor. Okay, that's if cardiology is in-house. We're willing to come down to the ED to do that. Now, I'd rather admit that person, so we've got it all monitored. So, the heart's not beating properly for whatever reason, and it can't maintain perfusion, the brain gets involved. So, structural disease, aortic stenosis. There's your classic triad. You better know that. You better know that. Not necessarily for my test, but you need to know that again. Any triads, pentads, whatever, we'll get into those things. They're going to be like, this patient has chest pain just beyond exertion. And syncope, they're like, oh, it's easy, or it's stenosis. That better be your answer. And that's all they're going to give you. And then we worry about this hypertrophic cardiomyopathy. So most common cause of sudden death, this is why we get EKGs on kiddos that are going into sports. So what do we see with hypertrophic cardiomyopathy? Dr. DeBoer teach you guys that? Did you dump it all from last semester already? It's okay. You're in the ED, I know your EKG is pretty good. So usually we're going to see that in all the precordials, right? Pretty high T waves, ST waves, not necessarily in the form of ST elevation, but it does this biphasic thing though, where it shows back up when people get over the age of 60. So it's a biphasic thing, young and then old shows back up. So just as far as your non-compliance, it's 3 different flavors. So some of these people can have restricted, dilated versus hypertrophic. But we're talking more of the hypertrophic flavor. So beware of that. And some other things we need to be concerned about. Always think of a PE on your differential. PE on your differential. Probably more in your older folks. What sells me on PE? So aside from the person syncopizes, I'm going to ask them, do you have pleurisy? I'm not going to ask the patient that. They're going to look at me like, what the hell is that? So when you take a deep breath, does it hurt? That's pleurisy. That's pleuritic chest pain. You take a deep breath in, and it hurts worse. I can't tell you how many P's I've caught younger people when I say, oh, you have chest pain, but only going to take a deep breath in. And my P dimer comes back positive, CT scan, usually not a big one, but I've had like a 24-year-old lady with like 3 massive PEs. She was a marathon runner. She couldn't run a mile, so that was red flag number 1. And then she said she actually coughed up blood, so that wasn't good. Sure enough, 3 massive PEs. If she'd been 60 years old, she would have never made it to the ED, which is a marathon runner, so she took it. I've had some people freaking try and crump on me pretty fast, so don't forget about that syncope. And then also myocardial infarction. That's the reason why the heart's not pumping properly, because it's infarcted. You now have a wall that's not working because it doesn't have any more blood flow to it, and now we're not perfusing the brain. So be concerned about syncope. Cardiac cause is probably being the most, with morbidity, if not mortality, if they can make it through. Patient gets arrhythmias, so we worry about looking at that right across, which is why I say EKG shows no electrical evidence of ischemia, infarction, or arrhythmia. And arrhythmia just covers all the bases with bradycardia less than 60, right? Usually due to heart block, usually, and then tachycardia over 100. So not to be confused with supraventricular tachycardia. How fast are we going with that?
200.
Well above 150. Well above 150. Usually closer to 200. Usually closer to 200. What do we do about that? What's the first thing we should do with the supraventricular tachycardia? Vagal maneuvers, right? Vagal maneuvers. Okay. That should be done with the rig by EMS before. And then we reach for what med? Adenosine. Okay, 6, then 12. New studies are showing 18. Please put the pads on before you give them adenosine. Kind of freaks me out when they go into asystole for a few seconds. Anyway, Brugada syndrome is what we worry about. Long QT syndromes. There's also this catecholamine-associated polymorphic ventricular tachycardia, also known as torsades. So just be aware of that. Syncope, suddenly, usually without prodromes. That's why I say cardiac syncope. Just think of grandpa. Suddenly, just look over and his face has been magnified. Didn't know it was happening at all. That is a cardiac syncope. That is concerning. That doesn't go home. What's this? What are those called? Delta waves, yeah. Pay attention to those. Pay attention to those. Those are delta waves. So this is what you're going to see in younger people. This is a fusion beat of normal conduction. So it's faster accessory ventricular activation. Probably not going to be on the test, but just be aware you need to look for those delta waves. You guys are going to get a chance to do a cardiology rotation, so make sure you get to do it on your pages. Please flip the top down. Don't read what the thing says. You'll get used to that, and your eyes will be drawn to it. Start looking at those without looking at that stuff. All right, clinical features, specifically vasovagal. Again, inappropriate vasodilation. This is the body's reaction usually to stress. These people are going to get bradycardic. So if you have them on a monitor, pretty interesting thing. So usually you see a lot of this. I see patients, they look down, they're getting an IV. Some of them will pass out. You can tell if you hold their hand, they start getting clammy, and then they're going to get bradycardic. It's always a fun game. Tell your medic, I think you killed them. How do I do that? So fun. Anyway, see something usually that says that it is a progressive onset. It's not like a sudden syncope. You usually start getting a little bit sweaty, clammy, and that happens. Usually happens what? Sight of blood. Why some people may never be able to go into medicine if they can't do that. So anyway, just be aware of that. So it happens if you go stand in formation and like close your eyes and think of concentric circles. It's going to happen. It's going to happen. There's all the different things, unpleasant sights, smells, fear, severe pain, coughing, going to the bathroom, and then that postural orthostatic tachycardia syndrome. So they're basically orthostatics and they're coming back fine. So they're just like, this is what we're going to call it now. So don't put that on like in your top 10 year differential, please. Like number 11. You want to put it there. So carotid sinus syndrome. So anybody that's doing any manipulation, that's why we're very cautious with older folks with checking a pulse in their carotids. Be careful with that. This happens sometimes with people that putting on ties. So carotid sinus, there's a baroreceptor in the internal carotid that essentially stimulates this to happen and responds to that. And so some older folks specifically putting on ties, or I think one of the scenarios that I've seen, one pants was a young grandkid was practicing like CPR and checking his grandfather's pulse. His grandfather's teeth stimulated that. So it's out there. Just know it's out there. Orthostatic syncope. So these are people who typically they're not drinking enough, typically dehydrated. So postural hypotension. So a drop in the systolic or the diastolic with syncope or pre-syncope. Nurses are not too fond of getting orthostatics, so you may have to be doing that on your own, but just make sure that you check these types of things on people. It helps you kind of rule out some of the bad stuff as far as that. So orthostatic, usually I get concerned about this. If orthostatic, if those do not come back normal, because I'm wondering if they're a GI bleed or some type of bleed that's internal that I can't see. Now your vitals should correspond with this, so they are going to be hypotense, but we do get concerned about things like sepsis. We'll get into that lecture next week, but we're about people severe vomiting, diarrhea, people on diuretics. But be very concerned about this type of thing in the elderly, because it puts them at huge risk for a fall. Maybe you're not so concerned about the fact that they syncophize, but now they've hit their head, now they have a subdural. So be concerned about that. Fall risk in the older folks, very concerning. And then you have your psychiatric. So some people, a large portion of those, almost half, have an underlying vasovagal. 62% unexplained, like majority of our syncopes are. So just realize that this can run with psychiatric illnesses. We have anxiety disorder and MDD, major depressive disorder, which is just a adjustment disorder that's been going on for longer than 6 months. So then you have your psychogenic pseudosyncope. So most of those people are going to be, again, if they're closing their eyes and you can't open them, it's fake. It's not really happening. So they think it's happening in their head, but it's not real. And then you get very concerned about your medication use. And I tell you this because anytime I put somebody on a medication, say Flomax, or either I'm treating their BPH, or I'm treating them to get their kidney stones, taking them to expedite their kidney stone, you got to be very careful with that, because most of these older folks that have that issue are already on blood pressure medication. already on it. So what do I tell them? If I'm giving Flowmax, which is an alpha blocker, it's going to help them out with that flow, pass that kidney stone, or help compete with that BPH, I'm going to say take it at night. Take your antihypertensive in the morning, take this one at night. If you take them both at the same time, you're going to get behind the wheel, you're going to pass out, and you're going to kill somebody or yourself. So that's medication induced, and not that they're doing that on purpose, but as people get older, they forget, oh, did I take my medication this morning? Oh, I'll just take it again. And next thing you know, they're taking too much, so just be aware of that. Beta blockers, calcium channel blockers, very concerning. There's something called one pill can kill. When we're talking about pediatrics, so when your grandparents come over, make sure their medications are locked up and whatever, because a pill falls on the ground, little Timmy crawls over, eats a calcium channel blocker, no bueno, okay? Not good for kiddos, so just be aware older people are going to cause that too, as well as nitrates and diuretics, plenty of those. Hydrochloric iodide, diuretic, that's probably one of the most common. Just be aware of those types of things. Here is a list of those types of medications. So things I just talked about. So yes, erectile dysfunction medications as well. That would be interesting if you got a hold of that. Just be aware. If you have older folks that come over, your grandparents are staying, make sure the medications are locked up. We don't want anybody wandering into that stuff. So I only tell you this stuff because it's happened. I've treated kiddos that have gotten into all kinds of things. I really don't like calling CPS. I don't mind if it's not accidental trauma, but it takes a lot for me to not walk out of the parking lot and see whatever. Neurologic. These are very rare. Very rare. So usually transient, so comes and goes. So, but there will usually be some persistent neurological deficits. So we worry about these. These are life-threatening. We see this with strokes. We see this with sepsis, and we see this with overdose. So overdose again. Block 3. I think the last lecture is toxicology. We'll delve into that a little bit, so you understand kind of how to handle those things. So here's an interesting one: subclavian steel syndrome. So there's this abnormal anatomical variant of the subclavian artery. So exercise of the ipsilateral arm, even the same arm that is on the side of the defect. So you can usually see a decreased pulse volume, diminished BP in the affected arm, which is why you potentially can get blood pressures on each arm to get an idea of what's going on with this. What is going on with this? So where does this happen normally? I say getting something out of the cupboard, grandma's reaching up, or let's say she's putting a star on top of the Christmas tree. That's where the subclavian steel happens. My grandma put the star on the top of the Christmas tree. Every time she did it, she farted. It was awesome. Probably a genie pie. Love you. All right, spontaneous subarach. Very concerned about that with syncope. So usually focal neurological deficits, headache. We're going to see some other symptoms that are associated with this. So unfortunately, when they syncopize, we can result in a head injury. So low suspicion if somebody suffered a fall. If they're older, especially if they're anticoagulated, I'm getting a CT of the head and neck. I need to make sure 100% they're good to go. So seizure can't get confused with this. We start muddying the waters with medicine, so you really got to kind of tease these out. We've talked about seizure already. That post-ictal state should set you off, but like this is a seizure and not syncope. Tongue biting, incontinence, and that epileptic aura. We need to make sure that we're looking at those types of things. Diagnosis. So goal is to look at the risk, make sure that we're eliminating that cardiac risk, because that's the one that's probably going to get us the most. Again, near syncope, the same way. So making sure, definitely getting good physical exam, neurological exam, making sure they can ambulate well with no gait disturbances, and then EKG, and then additional testing as needed. So hopefully somebody else is there that witnessed the event. Again, older folks do not necessarily want to be admitted to the hospital, so they might downplay things a little bit. You need to tease through that stuff. Figure out what events were leading up to that. Was there any change in position? Did you stand up real quick? What was happening around you? Strenuous activity, arm exercise clearly dealing more with subclavian steel. And then what did you have before that? Did you have any headache? Did you have any double vision? Did you have dizziness? Now, dizziness, lightheaded versus vertigo, you need to tease those different things out. Did you feel like you were going to pass out? Did you feel like the world was spinning? Ask those questions, get that idea. And of course, any chest pain or palpitations would lead you to think that maybe there's a structural or a dysrhythmia. And then how long were you unconscious for, and was that person post-signal? If their daughter tells you, man, they were out of it for like 30 minutes after that, you're like, oh man, that sounds much more like a seizure. So, chest pain, right there, red flags, palpitations, you need to ask all these questions. These are considered your review of systems. Review of systems, where you're going to ask, hey, and don't say, do you have palpitations? Unless they're a nurse, a PA, a doctor, they work in the medical field, they're not going to know. Say, did your heart feel like it was beating fast or fluttering or butterflies? You're going to have to use layman's terms to ask these people. Shortness of breath, headache. You have any abdominal or back pain? Was it sudden? Did you know it was going to happen? Because if they knew it was going to happen, it's probably more vasovagal versus a cardiac. Out of nowhere, and cardiac. I'm worried about cardiac dysrhythmia, structural cardiopulmonary lesion. Asking all these types of histories. That's why we ask past medical history. That's why we ask about all the social history. You should be able to tease that out. If they're not a great historian, you need to be able to get to a point that you can look over their medications. If they're anticoagulated, they're anticoagulated for a reason. So if they're anticoagulated, they've either had a history of a thromboembolism or an MI or a stroke. Let me tell you that right now. Why are you on Rivaroxaban? I don't know. And he told me today, okay, well, I'm going to be digging through your records. So most people are pretty good historians. Just asking all these types of things. More likely, if they've had 5 episodes in a year, it's more likely vasovagal or a psych issue versus some sort of cardiac issue. And then you always want to ask about any new medications. You're taking medications like you're supposed to, go on with that. So yes, you do have to be a bit of an investigator. Other things, aggressive dieting. Some people are trying to lose weight really quick. They're on some type of medication. Those are usually amphetamine based. Some people don't care. They'll just prescribe it. That's cash money in their pocket. So just be aware of that. So family history, any history of dysrhythmias in the family, sudden cardiac death. So sudden cardiac death. And then single car MBC sounds to me a lot like somebody passed out behind the wheel. It's a single car MBC. Most MBCs are going to involve 2 cars. Most. But every now and then you have a single and you have an old person coming in. I'm like, why did you pass out? No, not even. Okay, sure. I'm going to work that up. So just be aware if they were in a single car MBC, now you're dealing with a possible syncope, along with needing to work up to make sure what do they damage. And by the way, every MBC comes in, you should be asking, did you have to be pulled from the vehicle? How much intrusion was there? And did the airbags go off? How fast were you going? Things like that. So if they can't tell you all those types of events, then I'm going to be like, man, you probably passed out behind the wheel, didn't you? Okay, I don't say that, but that's what I'm going to work that out. So, seizure, most commonly mistaken as syncope or vice versa. So because can be a little bit of tonic-clonic activity, a little bit of twitching that happens after that. So again, I'm being repetitive. I know I'm being repetitive, so I don't need it in the course review. But just be aware. So post-ictal confusion, muscle pain, classic aura. I'm like, nope, that was something more like a seizure. You need to be able to differentiate between those two. Those are 2 very different workups. But maybe you work them up because you can't quite tell. You just work them up as the same. That means kitchen sink. Let's go. Get your safety net in place. Because if this is more of a cardiac issue, it may just come right back. So we get them on the monitor, we get an IV in, and we make sure that we're doing things. O2, if needed. Again, some people are like, oh, he's 92. No, 92 is fine. Below 90 is when I start getting excited. Cardiac monitoring, super important. That's clicking a button, and the nurse will go in and put leads on, and they are completely being monitored. And guess what? That thing will start beeping if something's not feeding properly. So, potential to put defib paddles on, put those on in the emergency department, put those on in the emergency department. So. Alrighty. So, orthostatic hypotension, you can do your tilts, so to speak. So abnormal orthostatic blood pressures usually drop in more than 20, and then decreases systolic. So I had a gentleman in downtown Tacoma. Gentleman came in a 2-story fall onto his face.
Oh, holy crap.
He did make it. He didn't make it. But what I thought was interesting, so his dentures were broken in probably 3 different parts, some in his nasopharynx or pharynx. I had to tube him. He herniated and didn't go well. But what was weird is no injuries to his arms, even though he fell onto his head. I'm pretty sure that guy syncopated, whatever. It's probably a cardiac issue. So no injuries to the hands. I'm sorry, I'm going to try and stop my face from the ground. Unless I've had too much to drink, like whatever. Anyway, cardiac exam, that's why we have you listen to that. I would encourage you, because you're mostly listening to each other and everything sounds normal. There's plenty of different apps, stuff on YouTube that you could listen to start hearing things that are abnormal. You get a chance to do that in your cardiology rotation, hopefully, and listen to people so you know what aortic stenosis sounds like, you know what these types of things, HOCM, whatever. So neuro exam, make sure you're good on that. WIAC, why are we concerned about that? Because maybe we don't know if they have a GI bleed. So they're hypotense. Why is that person hypotense? Not every old person looks at the toilet after they take a bathroom break, right? So most of the people don't. Most of the time they notice it when they there's blood on the paper. So do not do a carotid massage in the ED, but your history, getting all that teased out is very important. And then our ECG, very important. Very important. So we're looking at that. Hopefully we can compare it to something else, looking for heart block. A new or a old left bundle branch block. Very, very concerning. So that's nice to have an older one to look at. So what do we see with left bundle branch block? See if you guys retained anything. So usually widening of the QRS in the precordials. Widens. Okay. Negative QRS in V1, and then notching of the QRS in V6. Pay attention to those things. Now, you're like, I'm reliving junior semester. I'm telling you, EKGs are not going to go away. I can't tell. I saw at least 10 EKGs on my pantry. At least 10. So, know that. All right. Lab testing, not always useful, but we'll show you some decision-making tools with that. So if that's CBC, if you want to work it up, say CBC, I'm going to make sure they're not hypovolemic. You check that. HCG if they're childbearing. Why? Because women that are pregnant are at higher risk for pulmonary embolism. I'll tell you that right now. And I think about 2 years ago, I sent home a young ICU nurse that had just had some lightheadedness. I worked her up completely. She went home and came back in. She was pregnant, fixed and dilated 12 hours later after I was off shift. Yeah. That ate me up for a little bit. But the first thing I said, looked at my chief, I said, look at my note. I got anything to worry about? Nope, you worked her up more than I would have. So probably went home and had a massive PD. And didn't come back in. So tell your people strict return precautions, come back in. She blew it off. So just to be aware of those types of things. Worry about troponins or worry about cardiac stuff. Troponin's going to give us an idea if there's ischemia going on or infarction. What's a BNP? I'm going to tell you. Remember, there's dilation of the heart, indicative of congestive heart failure. Indicative of congestive heart failure, so BNP. That's why you order that. We order the BNP to differentiate between, is this CHF or is this COPD? Because they're having shortness of breath. But their legs are usually pretty swollen, you listen to the lungs, but I digress. So, other ancillary testing, I don't recommend doing this, but it is in the book, so I got to teach it. Hyperventilation maneuver. So if you think it's psychiatric, you can basically give them anxiety by having them do that, and then they pass out. That's terrible. Don't do that. But it's in the book, okay? Neurological testing, obviously, potential that maybe they need EEG, LP, CT. You can do the LPs and CT, they probably need to be admitted for that EEG. And then worry about that pulmonary embolism. Please have that in your top 3 differential for syncope. Please, please, please do that. Again, should be associated with blurred chest pain, but beware. So H&P and EKG, everybody gets an EKG if we're worried about near syncope or syncope. Everybody's getting an EKG, regardless of age. I don't care. Because if it's a dysrhythmia, it's probably going to be a younger person. If it's structural, it's probably going to be an older person. But I want to make sure I get that taken off the plate. So cardiac or neurologic related, it's getting admitted. So vasovagal medication, we want to make sure that we work them up potentially, or we don't, but make sure they have strict return precautions and that it's not cardiovascular related, and we usually do not need admission. They can go home with some reassurance. So, how do we work this out? This is what I use. This is the Canadian Syncope Risk Score, and it involves all these different types of things applicable to the age of 16 or older, and this is 30-day serious outcomes. And this is what I'm going to run everybody that has a near syncope or a syncope. I'm going to run this score and I'm going to document it. If it's a 0, I'm going to put a 0 in there, and that 0 makes me feel very, very comfortable sending that person home. Very comfortable. If it's elevated for any number of those reasons, and here it is for you, it gets a point, then I'm going to call somebody, and after I tell them all about my patient, I'm going to say Canadian Syncope Risk Score of 7. Please come down, put your hands on my patient, and admit them and work them up. They can't fight that. You can't fight that. So you use this tool to discharge people, you use this tool to admit people. If you tell them that score and you've run the numbers, well, I had a resident that was like, this guy can go home. I'm like, really? What's his score? I didn't run it. I'm like, well, stop looking at me. Keep going. He runs the numbers. I'm like, still want to send him home? He's like, no. Oh, shit. By the way, that's somebody's mother, somebody's aunt, somebody's daughter, whatever. And this is how that equates out as far as the numbers. I'm not going to have you calculate the Canadian Syncope Risk Score. I'm not going to have you calculate that. I just need you to know that this is a great tool for you to use in the emergency department. Great tool. So, right there, very low risk. I can discharge. I just right there. High risk, 3%. Very high risk, 9%. What does that mean? Those are percentages of people that died. Those percentages. So, that high risk, that 3%, 3% of those people should have been admitted, but they end up dying. 9% of the very high risk die. 1 in 10. That's concerning. Very concerning. So, getting that EKG is going to be very helpful with that. If you see abnormalities, hopefully you have an older EKG to compare it to, just to make sure. If there's samesies, cool. So, EKG monitoring, put them on telemetry. So 2 hours of observation with that low risk patient, 6 hours for non-low risk. Will typically detect half of the arrhythmias, provided they are in telemetry that entire time. Because people have this thing that gets paroxysmal, meaning it comes and goes. They have AFib, goes away. An hour later, it shows up again. Most of those people can tell, but they're not sure what it is. They figure it out. Anyway, so risk factors. I get really concerned, higher spidey sense, if you will, over the age of 60 to 65, history of heart disease, abnormal EKG, higher troponin levels. Are there people that walk around that have what's called troponemia, meaning they always have an elevated trope?
Probably.
It freaked me out the first time. I'm like, oh crap, he's having a STEMI. And then I look back in the records and I'm like, hey, this trope's normal. It's just always elevated. Some people just have that kind of thing. So, got to do a little bit of investigating. So, abnormal systolic blood pressure, and then that story that tells you it was sudden onset. Syncope is very different than cardiac. So no prodrome, bam, on the ground, maybe with palpitations. So your treatment's going to be guided by diagnosis. We're concerned about a cardiology, etiology, then you need to get cards on board. They're going to bring that person in. I've had plenty of folks that have had internal implantable defibrillators. Had a 24-year-old come into Madigan. We had everything on video. He was in combatives. He syncopized, got back up, and then promptly went into cardiac arrest. 24. The 13th round of CPR, we did what's called a double sequential defibrillation, meaning hooked up 2 defibrillators. He was already amnio loaded, epinephrine, we've done everything. 13th round, and this guy's cold. I was like, done. I looked at one of my docs I was working with, was working his code, and I said, when do we stop? He goes, he's fluctuating between VFib and torsades. He goes, he's got a shock already, and we're going to keep going. So just double sequential, got ROSC, he got an implantable defibrillator. I talked to him 3 days later. Didn't remember a single event, but
good thing he didn't stop.
So never actually figured out what happened with that guy. Obviously, you get an implantable defibrillator. You get to get out of the army. Yeah. So medications, so rehydration, low threshold to pull the trigger on giving people IVs in the emergency department, especially if we're dealing with syncope. So, and then just educating these people on vasovagal. Don't look at blood. Make sure you're drinking plenty of water. So people want to gauge it. I say half of your body weight in ounces daily if you're watching football in the AC. That's what I tell people. Like, oh, okay, let's take glasses, half inch glass, or whatever. The low risk, DC home, intermediate, shared decision making. There is this thing in the emergency department that's called shared decision making, where I will go and talk to patients, and we will decide what is the best way to handle things. So I've admitted patients that were like, if you don't admit him, I have to pay for the ambulance. I'm like, all right, I'll get whatever. And then high risk, so I'm concerned about those cardiac types of things, and then I'm concerned about CHF as well. So CHF, usually you're going to know those people because they have underlying CHF. They're on a diuretic, they're on a beta blocker. Pretty easy to tell. All right, check on learning. And let's see, what time did I? Oh, I ran way over, didn't I? You don't care that. Sorry. Nobody, if I go that far over, it's a pain. Sorry, I was in the zone. I was like,
Oh, no.
I'm excited it's Friday too, okay? All right, questions on syncope. The next 4 blocks, if you look at the amount of deals, we're doing as much as we can next Thursday because you have lunch anyway, and hopefully finish earlier on Friday, and maybe go ahead and plan on whoever you have Friday afternoon and maybe showing up a little bit early. All right, questions on syncope. Major Sandoval has a bunch of goats at his house. I want to go over there and feed my thing, but I do. They're cool. Can't potty train them though. That sucks. We'll get to kill some later this semester. All right. So remember back. You need to know this. What's the most common etiology? Unknown or idiopathic. Idiopathic. Don't use that word at a bar to get your ass kicked. Branson's. So what you'll see probably on the pants is that somebody's putting on a necktie and passes out. So they've done studies that like reduces like 10% of blood flow to the brain by wearing ties. That being said, I went to a private Catholic all-boys school in high school. Wore a lot of ties. A lot of shenanigans, yeah. That one's pretty easy, right? So plating steel.
Yeah.
All right. And I will, for your very first EMED, I'll make sure after we finish up with the last lecture, I will give you guys a review, because there's a couple of you that are just going to crush it. But EMED was tough for me, and look what I went and did. It makes a lot more sense when you're actually doing it. So, alrighty, folks. Are you done for today?
Yes, sir.
Bullshit. On to the next lecture.